everybody. My goodness, you're good at getting quiet. Welcome to this afternoon's talk on neurocratic futures in the disability economy, pregnancy, addiction, and mental illness in the U.S. welfare state. Sponsored, as you know, by the Institute for the Study of Societal Issues, and I'm Jane Golden. I am the acting director for the ISSI, and I'm also a faculty member in the Children's Policy.
Hey Jane, use the mic, would you?
What?
Use the mic. Can't really hear you.
Right. No, I guess I can. No, okay, fine. I'll just stand here. Fine. But before we get started, I would like to announce an upcoming event sponsored by one of our SSI's centers. On Monday, November 4th, the Center for the Research on Social Change will host a screening of a movie, Just a Piece of Cloth, 34-minute documentary featuring 4 San Francisco Bay Area Muslim women from diverse backgrounds talking about what the hijab, the traditional Muslim headscarf, means to them and how it affects their daily lives. And following the screening, there will be a discussion of the filmmaker between the Professor of Linguistics and Language Development at San Jose State. And this university will take place in 691 Barrow School, fortified city. There will be popcorn. So that's Monday, November 4th. And then we will have another talk here on Wednesday, November 6th, too. And I'm not going to announce that. Watch your emails. Now, just a reminder, to turn off the cell phones and also to sign the sign-in sheet, which should be coming around. Somebody has the sign-in sheet?
It's in the back, so people can just sign it on their way out, maybe?
Well, should we pass it around? Oh, sure. All right. So it's my pleasure to introduce today's speaker, Kelly Knight, who is assistant professor in the Department of Anthropology, History, and Social Medicine at UCSF School of Medicine. And she's a faculty affiliate at Diocese newly formed Center for Social Medicine. Professor Knight is a medical anthropologist who has conducted social research on drug use and addiction for 20 years in the San Francisco Bay Area, addressing topics such as HIV/AIDS, sexual risk, reproductive health, drug treatment, housing, violence, mental health, and welfare and health policies. She has numerous publications, including a new book, Limited Addiction, Pregnancy and Madness in the Daily Rent Hotels, which is forthcoming from Duke University Press in 2014. Please join me in giving a warm welcome to Professor Knight.
Thank you all for coming. Before I start today, I'd like to thank the ISSI and Seth Holmes for inviting me to present my work as part of the Fall Colloquium Speaker Series, and also Christine Trost for helping me to get settled here as an in-residence faculty member. I'd also like to acknowledge several people. I'm standing up here by myself, but of course there are many people behind me who've contributed to my thinking and helped shape my work. Specifically want to thank Vincent Adams, Philippe Bourgois, Charles Briggs, and Lawrence Cohen, who all offered comments on this work at various stages of its progression. The women of the Daily Rent Hotels in the Mission District of San Francisco, who allowed me into their lives and shared so much with me during my 4-year project and still do today. I also want to thank the psychiatrists, physicians, neuroscientists, drug treatment providers, policymakers, and benefits advocate counselors working in the safety net healthcare delivery system in San Francisco for taking the time to answer my many questions. And finally, the volunteer staff of the Women's Community Clinic Outreach Program and Ladies' Night. All these people took my project extremely seriously, and for that I am happily and thankfully indebted to them. In this talk today, I hope to accomplish 3 things. First, I'd like to describe the 1990s era U.S. welfare reform policies and associated claims made in the public media about motherhood, drug use, entitlements that have impacted today's management of pregnancy, addiction, and mental illness. Second, I'd like to identify how the local bureaucratic and clinical practices have created a disability economy built around the diagnosis and documentation of specific forms of mental illness. This disability economy is responsive to the everyday trauma and mania experienced by the urban poor, while also seeking seeking fiscal restraint in the allocation of health care between cities, states, and the federal government. Lastly, as the implementation of U.S. healthcare reform staggers forward, I hope to offer some reflections on mental health and addiction parity in the context of poverty. I'll introduce the complex relationship between pregnancy, mental illness, addiction, and poverty in the way it was introduced to me. When I first met Lexi, here's an excerpt from a field note from February 2004 from a homeless drop-in center in the Mission District in San Francisco. Here's the note. I'm on site to recruit women and men for a small qualitative study about the impact of care not cash, San Francisco's welfare deferral and housing policy. I meet an African-American woman about my age, early 30s. She's very eager to be interviewed. And I ask if she's on general assistance, and she says not anymore. We go upstairs to the room the drop-in center is loaning me for interviews, and we talk for several hours. Lexi is homeless, sleeping with her husband off and on in the parking lot of the bread factory 3 blocks away. The bread factory tolerates the homeless as long as they can clean up and disperse when the morning shift starts. Lexi has a tent. She says it's pretty okay as long as the men don't get too drunk and start to hassle her when her husband is gone. We talk welfare, drug use, housing, and family. These are all connected to a recent painful experience for Lexi. She lost a baby 4 months previously. She describes her confusion about why the hospital couldn't save her daughter, born 6.5 months when Lexi's cervix opened prematurely after she was rushed to the hospital high on crack. She says, when they handed her to me, I thought she would just be, I don't know, I didn't think she would be a baby, a full baby with hands and feet. And she stops and starts to cry. Lexi's access to methadone maintenance treatment was linked to her pregnancy through a special program seeking to expedite pregnant women into drug treatment for opioid addiction immediately upon request in San Francisco. When she left the hospital after her daughter died, she was detoxed and had to scramble to find another funding stream for her methadone. As her health status changed from pregnant addict to just addict, so did her ability to make claims on the state for drug treatment access. She was put in touch with a social worker who could process her needs, and immediately the social worker encouraged her toward SSI, or Social Security income. Lexi tells me, the caseworker said, you have PTSD. You haven't dealt with the death of your daughter. You are in trauma and you can't work. Lexi tells me, I told the caseworker, no, I've always worked. I came to this life late, to drug use late in my life. I used to work. I didn't want to give up like that. But that was it. I had PTSD. And you know, I did have it. I did have PTSD. I mean, of course I did. But I just didn't want it to mean something for the welfare. As Lexi's example demonstrates, teasing out the causal relationships between mental illness symptoms and substance abuse behaviors is complex on the ground. This difficulty is an unforeseen consequence resulting from the collision of federal neoliberal welfare reforms seeking to defund addiction as a disease and complementary actions taken on the local level in San Francisco to diagnose mental illness in order to treat poverty. Following Beale, I see mental health diagnostic practices in this setting as having become displacements, pivotal bureaucratic events designed to manage material suffering, which reference larger ongoing ideological and political debates in the United States about healthcare access equity and the entitlement rights of the urban poor. The larger story I tell about addicted pregnancy constitutes 10 chapters in the forthcoming book. Today I'll focus on 2 of those chapters, examining addicted pregnancy through the lens of welfare entitlement, disability, and mental illness. Obviously, there's always a larger story. In light of this being an interdisciplinary audience of not just anthropologists, I thought I would spend a minute talking about methods. I conducted a 4-year ethnography of addicted pregnancy. This involved extensive field work in private, daily rent, single room occupancy hotels where I documented 23 pregnancies among 19 women. During my field work, I spent hours upon hours with women while they copped drugs, sold sex, hung out, went to drug treatment, left drug treatment, attended appointments for mental health and physical health, were hospitalized, had babies, and lost children to the state. I also interviewed over 40 stakeholders. I call them those who had various disciplinary expertise relevant to the management of pregnancy, addiction, housing, and healthcare in San Francisco. Lastly, I analyzed the work of other social scientists, epidemiological data, government position papers, and welfare reform policy documents from the 1990s to the present day to outline the larger context of drug use, disability, entitlement in the United States. In epidemiological narratives about pregnancy, addiction, and mental health, one often sees both comorbidity and cost sharing pride of place. Documentation of the co-occurrence of substance use disorder and severe mental health conditions is widely documented in public health and clinical literature. For example, epidemiological data from national study sampling adolescents and adults entering drug treatment, that's here, states that over 70% of those entering drug treatment report a co-occurring mental health problem. The U.S. Substance Abuse and Mental Health Services Administration, or SAMHSA's National Survey on Drug Use and Health estimates that nearly 2 million women aged 18 and older were estimated to have both a serious mental illness and a substance use disorder. At the local level, the San Francisco Department of Public Health directly funded the generation of epidemiological and clinical data from the largest public hospital to document the significant relationship between comorbidity, patient poverty, and healthcare costs. This data charted the, quote, frequent flyers, homeless and marginally housed persons with substance use problems and mental health issues who monopolize public resources through frequent trips to the emergency room and preventable hospitalizations. My role as a medical anthropologist was to travel from these epidemiological cohort studies and the healthcare policies they shape to the everyday social and institutional environments where women manage addiction, pregnancy, and mental health on a daily basis and back up again. In my work, poor pregnant addicts living in single-room occupancy daily rent hotels found themselves enmeshed in a complex web of addiction, mental health diagnosis, and housing instability, in which specific forms of social recognition were in operation. One provider described to me how the urgency and complexity overlap to make the management of addicted pregnancy particularly daunting as a health, mental health, and social service problem. She said, "Pregnancy isn't a long time. It may seem like 9 months is a long time, but to get a woman stabilized on methadone, to get them prenatal care, to deal with their housing issues, to get them signed up for Medi-Cal, get a psych evaluation, follow up if they need it so they can deliver a baby with only methadone on board and not get a Child Protective Services or CPS case, it's rarely enough time. If women arrive to us at 7.5, 8 months pregnant, chances are they have all of these issues that will get you tagged by CPS. They've been using throughout their pregnancy, they might have a severe mental health issue, they're in denial about the pregnancy, and they're probably unstably housed. At this point, we are just barely able to put out the fire, get them on methadone, and off everything else. The pregnant addicts I studied were living chaotic, dangerous, and stressful lives in the daily rent hotels, engaging in ongoing drug sex economy hustles to avoid homelessness, feed their addictions, and deaden their rage. The private-owned daily rent hotels in San Francisco's Mission District charge between $35 to $60 a day to rent a single room. None of the rooms have bathrooms, and most look like the ones pictured here: stained walls, dirty, broken furniture, chipped, peeling paint, often with blood stains and graffiti on the walls. Most rooms have terrible bed bugs, rats, mice, there are flies everywhere, and often garbage in the hallway, along with broken TVs, dirty bed sheets, old mattresses, and other odds and ends. The hotel owners make a tremendous amount of money from charging renters daily, accruing renter debt, and displacing renters prior to them establishing tenancy rights. The primary source of this income for hotel owners is through the charging the clients of sex workers visiting fees. Charging visiting fees is illegal in the city of San Francisco, yet it's widely practiced in the hotels in which I conducted participant observation. This is how it works. A woman rents a room for a day, paying, say, $50. Every trick she brings up to the room has to pay the manager a $10 fee for the visit, plus the cost of the sexual transaction. While publicly subsidized hotel rooms can't garner more than 30% of a tenant's income, the profit potential for private hotels operating as brothels is much, much greater. Structural violence of the daily rent charges in the private hotels and the ways in which the hotel's metric of cash is inextricably bound to the gender drug sex economy is demonstrated well in this slide. The lettering has been changed so it reads, instead of daily rate $35, daily rate $35, poignantly capturing how violating the experience of life in the daily rent hotels can be. offer this lens into the economic realities of debt, addiction, violence, and exploitation for two reasons. First, I want to situate the everyday experiences of the women that I engaged with who became pregnant while I was doing my field work. And also because we'll return to it later when we explore how post-traumatic stress disorder and bipolar disorder are clinically assessed and managed for addicted, unstably housed women. However, now I'd like to move back in time and outward in scale to the 1990s welfare reform debates, which created the context for the neurocratic future so many women in the daily urban hotels came to experience. To understand how disability as an entitlement category became a moving target as a result of the 1990s welfare reform, one must first engage with the simultaneous relevance and irrelevance of comorbidity as a significant characteristic shared among the urban poor. Nora Volkoff, the director of the National Institute of Drug Abuse and pioneering proponent of a neurological understanding of addiction as a brain disease, affirms the common sense of comorbidity by reinforcing the notion that addiction itself is a mental illness. She highlights the complex pathways of causality between addiction and mental illness, saying the following. This is Nora Volkoff. To help explain comorbidity, we need to first recognize that drug addiction is a mental illness. It's a complex brain disease characterized by compulsive and at times uncontrollable drug craving, seeking, and use despite devastating consequences. Behaviors that stem from drug-induced changes in the brain structure and function. These changes occur in some of the same brain areas that are disrupted in various other mental disorders, such as depression, anxiety, or schizophrenia. It is therefore not surprising that a population survey shows high rates of co-occurrence or comorbidity between drug addiction and other mental illnesses. Even though we cannot prove a connection or causality, we do know that certain mental disorders are established risk factors for subsequent drug abuse and vice versa. It's often difficult to disentangle the overlapping symptoms of drug addiction and other mental illnesses, making diagnosis and treatment complex. That's Nora Volkoff. A San Francisco health official who I interviewed was more straightforward in the quantification of comorbidity, saying the following. Of all the people in supportive housing in San Francisco, 93% have a major mental illness that we can name. That is very, very high. 80% use cocaine, speed, or heroin every 30 days or get drunk to the point of unconsciousness. There are no more disabled people in this country. The fiscal burden of comorbidity among the urban poor propelled the public health officials in San Francisco to investigate the mass movement of this population from city and state funded welfare entitlements onto the federal welfare rolls. Ironically, the history of that local policy evolution stems from the nationally expressed political need to delink addiction from mental illness, to make comorbidity irrelevant because of assumed welfare fraud. This process began in the late 1990s within the context of long-running and fiery national debates about the worthy and unworthy poor. In 1996, the United States Congress approved a set of welfare reform policies called the Contract with America Advancement Act, which was signed into law by then President Bill Clinton. Many reforms were included in Public Law 104-121, but chief among them, from the perspective of San Francisco urban health, was the decision to deny supplemental security income, or SSI, and Social Security disability insurance for those individuals who claimed drug and alcohol dependence as their primary disabling medical diagnosis. Several political economic developments led to the change in SSI and SSDI eligibility criteria in the late 90s. First, the number of persons applying for SSI under drug and alcohol dependency category had exponentially increased from 1989 to 1995. Just to give you a sense of the numbers, in 1989, 16,100 people were claiming that as their primary disabling diagnosis, and by 1995 it was 130,924. So the net federal payout had increased substantially. Second, the political climate during the same period supported broad measures of criminalization for substance users, like mandatory sentencing laws, restriction on housing and job training for persons with drug-related criminal offenses. This amounted to a zero tolerance for public support programs serving persons with drug and alcohol dependence issues. Mediated images of welfare queens and crack moms were in high circulation during this period, painting a racialized picture of women who were abusing entitlement programs through their irresponsible and reckless reproduction. Joining this public discourse about pregnancy and addiction were multiple national media stories reinforcing the suspicion that drug addicts were using federal SSI welfare dollars to buy drugs. A physician offered clinical evidence of the added harm of federal entitlements for substance users in the public media and in a peer-reviewed public health journal. And one epidemiological study found that SSI entitlement enrollment was associated with increased drug use. After 1997, the complex relationship between addiction and poverty had been reconstituted from a disabling medical condition, addiction as a disease, to an immoral, malingering set of criminal behaviors, using welfare funds to buy drugs. Detractors argued that the fact that some drug addicts and alcoholics might choose to spend their money on substances rather than on a place to live proved the point that addiction was in fact a compulsive, progressively detrimental disease that overtook the minds and bodies of addicts. At the time, the general public and congressional policymakers did not share this view. It was argued that SSI benefits were enabling addiction. The public sentiment that was expressed was that addicts could work in paid employment if they chose to spend, yet they chose to spend the government's money on alcohol and drugs instead. As a result of the disability policy change, individuals could no longer claim disability based on the medical evidence of addiction. And you can see it where it says on the D, A, and A, that top slide there, and then there's that sharp drop that's reflective of welfare. One could, however, reapply under another diagnosis if it were adequately documented in the medical records and win back SSI entitlements. One epidemiological article made the case that most health providers, be they physicians or drug treatment counselors, recognize that in addition to substance use disorder, many addicts also had mental health problems, depression, trauma, schizophrenia, and mania. However, documenting and distinguishing between those medical conditions was not a clinical priority prior to the SSI disallowance of addiction. After the change in eligibility, it became both a clinical reality and a political necessity to document other physical conditions and or quantifying psychiatric conditions to regain access to SSI benefits. A policy brief from the National Poverty Center reported that, quote, by April 1999, only 35.5% of former drug and alcohol dependent recipients had requalified for SSI under other medical conditions, most often a psychiatric disorder. With the changes in disability entitlement, the neurocrat was born. The neurocrat is a person who amasses an assemblage of evidentiary documentation, clinical diagnosis, medical history, employment history, or lack thereof, proof of poverty, and other certifying paperwork that must be collated to claim federal SSI disability benefits. What is significantly different about neurocratic processes as opposed to other forms of beneficiary advocacy, which are certainly not new or specific to 21st century San Francisco, is that neurocrats must evidence serious mental illness in the exception of substance use. Since 1997, SSI and SSDI disability documentation has included a box in which neurocrats must testify, evidence through the accompanying documentation, that the individual in question is suffering from a mental illness that is not induced by their substance use. This box becomes the technocratic trace that delinks addiction from mental illness and renders comorbidity bureaucratically irrelevant. There are many complex moral, social, and scientific reasons as to why neurocratic futures became so common among drug users in San Francisco in the late 1990s and early 2000s, and still today. The necessity to stave off the loss of services resulting from SSI defunding was a driving force, but the reduction in healthcare costs was also a clear impetus. In 1998, the San Francisco Department of Public Health adopted a, quote, single standard of care as its mental health policy, meaning that the uninsured would have the same level of access to mental health care as the insured. In the state of California, when SSI is awarded Medi-Cal, California's version of Medicaid, is also granted. Therefore, hospital-based and other health care costs and the cost for mental health services could be billable to the federal government by the city if the person receiving those services were attached to the federal disability program. The unrecouped profit for the city of not getting the 5,000 persons they identified in the late 90s as eligible but kicked off SSI amounted to a potential savings for the city of $27 million. Put simply, according to one policymaker I interviewed, costs matter, money talks in city government. Keen to take a closer look at how neurocratic practices were actually deployed, in 2009 I attended a strategy-based 3-hour training session in which a benefits professional informed the audience on the how-to of winning SSI and SSDI cases. The trainer perceived his role to be that of revealing the socio-cultural logics of the Social Security Administration's disability program by laying bare the definitions and details that matter. To that end, he was direct about the lack of value added to maintaining any politicized perspective on the illness experience when entering into the process of pitching an SSI case. Reading from his handout, he told us, the definition of disability is that, quote, an individual is unable to engage in any substantial gainful activity due to a medically determined physical or mental impairment or impairments. Unquote. Okay. The result of that impairment has lasted or is expected to last for 12 months or is expected to result in death. This is just him talking, not quoting from the handout. Now, I've been working in HIV and AIDS back from years ago, back when people were dying, within a year or two. And when you deal with the Social Security, you have to realize that even though we know that HIV and AIDS could result in death, they, the Social Security, have never acknowledged that portion of it. I've never seen them acknowledge that. Okay. When you have someone who's dealing with a form of cancer, they will acknowledge that. That disease can be fatal. If you have someone dealing with another life-threatening illness, they will acknowledge that. I'm just telling you what is. I'm not telling you it's right or wrong, good or bad. I'm not going to tell you how to politically change things. I'm going to tell you what is so you're successful at winning SSI cases. He continues. You see, SSI benefits is very much like a dysfunctional family. Don't make any common sense. Never have, never will. It's just the way they run. They're made by lawmakers who mean well, and they create law after law after law after law after law. And then what we've got is what we have today as a benefits system. And the consumer goes to access that system and they go, whoa. And the sad thing is that there are so many people who should be able to access Social Security wind up with what I call a diagnosis of post-traumatic benefits syndrome. The trainee implied that if you don't have a mental illness, if you didn't have a mental illness before, you might get one trying to get your disability approved. Drawing out the trainer's analogy, benefits advocacy was an exercise in moving poor women substance users from one dysfunctional family, their families of origin, their life in the daily rent hotels, into another dysfunctional family, an SSI home. It would be a mistake, though, to assume that this was a lateral move. Moving on to SSI might not solve all the problems that women drug users were facing or have faced, but it does more often than not give them some financial stability and increase the likelihood that they get inside in better housing and may receive some mental health care. SSI acquisition is viewed by both clients and policymakers as a social investment in housing stability. One policymaker told me this. With harm reduction and the integration of mental health and substance use treatment services, I think there's more knowledge. Specifically in relationship to SSI, there's an understanding that if you get someone housed as a benefit of the entitlement advocacy of the neurocratic practices, you can work on those mental health and substance use issues much more effectively than if they're not housed. Lexi provided an extraordinary description of how biomedicalized categorizations of mental health now circulate in her everyday life, when I quite accidentally discovered her neurocratic paperwork. This is in September 2009. Lexi and I are going to pick up some paperwork on her son, Lionel, who is in her mother's care. We park in front of Child Protective Services building while Lexi is telling me about a long-term trip, Gregory. She's afraid he will get picked up by the police because he always parks in the same place every day. She explains that she has, quote, trained him not to want sex too often, but she still gives him a blowjob or a hand job every day for $40. Gregory is upset that Lexi hasn't been available since her recent hospitalization. I wonder if he's also worried about her. I've met Gregory, and he takes care of Lexi by giving her food, gifts, and clothes constantly, as well as money. He sees himself as her benefactor. He even celebrates both his own and her birthday with a party in which Pano, Lexi's husband, is invited as well. Pano, Gregory, and Lexi hang out often. Lexi suddenly realizes she doesn't have her phone. Pano is just waiting for me to leave my phone, she tells me. If she leaves her phone in the hotel room, she fears Connie is going to sell it for crack, which is likely. She gives me a piece of paper to hold while searching for her phone. What's this? I ask, looking at the form with a bunch of numerical categories coded on it and boxes to check. The codes look like diagnostic codes for mental, physical, and behavioral health conditions. Lexi tells me, oh, I was just doing my research. She says, I was pretending like I was a drug counselor and I was filling out this stuff here. She shows me the form, pointing to a question. I pretended like I was a social worker or something. She laughs. See, I was actually trying to figure this out. See on the back, she flips over where there's a list of number and associated diagnostic conditions are listed. See, I was pretending that I had a client in the mirror and I was talking to them. Okay, what's your name? How long have you been using alcohol? And then I fill out the code in the front of the paper. See, this is for the Department of Public Health. This is confidential patient information. You see this? Pointing to the place in the form where it says confidential. This is for data and shit. She finds another form in her purse that is filled out. I just did this one for myself, she says. See, primary diagnosis. Okay, so my primary is a 294AA. But you see, I should have put a 3 there because I was referred by myself, not by the police. I was just playing them, pretending she means. Because those numbers aren't right. See, the way you do it is, okay, access 1. Mine is, flips over the sheet, flips it back. A 303-0X. No, wait, that isn't alcohol, that's heroin. But anyway, you get it. There's codes for all that shit. She continues. See, there's a bunch of them. And she's quoting from the paper. In the last 30 days, have you visited an emergency room? Yes, she indicates. Visited the psych yard? Yes, she indicates. She quickly mumbles through several other questions. Jail, 12-step, physical health problem, diagnosis, TB, hepatitis, children in placement, children in the home. This is a trip, she says. Living arrangement, primary source of income. This is a trip. The clinicians I interviewed were well aware of the disjuncture between their clinical tasks and the neurocratic documentation necessary for reimbursing their services and stabilizing their clients. One clinician told me, there are 2 different directions, unfortunately, that we have to go. When the patients show up in our clinic, in our city mental health clinics, we need to emphasize their psychiatric disorder as the primary problem. That's so we can get help. But clinically, their primary issue may be the use of alcohol, and that's what I spend my time working on with them, even though they have a mood disorder that may be secondary to their alcoholism. The neurocrat translates one form of clinical reality, the documentation of diagnosis, into a materially legitimate social categorization that leverages material gains, both for drug users and for the city itself. SSI advocacy-generated neurocratic evidence has not canceled out the clinical DSM categorization. It has multiplied its significance. It has pushed physicians and psychiatrists toward new ways to document mental health disability. Disability for the drug-using urban poor population in San Francisco is a diagnosis of intersecting poor health and poverty. Nicholas Rose, who has spoken of new, quote, technologies of truth, ways of counting, categorizing, and making visible, which have given birth to our, quote, neurochemical selves. He identifies the broad changes in our conception of the human that truth technologies have created in the wake of emergent biological psychiatry. This is a quote. The new thought style in biological psychiatry not only establishes what counts as an explanation, but it establishes what there is to explain. The deep psychological space that opened up in the 20th century has flattened out. In this new account of personhood, psychiatry no longer distinguishes between organic and functional disorders. It no longer concerns itself with the mind and the psyche. This is a shift in human ontology, in the kinds of persons we take ourselves to be. It entails a new way of seeing, judging, and acting on the human normality and abnormality. It enables us to be governed in new ways, and it enables us to govern ourselves differently. The neurocrat in this setting serves as the go-between. The neurocrat is dependent on the veracity of technologies of truth that privilege medical evidence above all other forms. Yet the neurocrat also produces evidence in the translation of clinical diagnosis and symptom terminologies into entitlement legibility. The neurocrat's job is not to identify labor to reveal a potentially productive poor. Rather, the role of the neurocrat is to make the madness of poverty legible. The neurocratic constitution of the madness of urban poverty cripples the potential for the beneficiary to be productively to productively participate in society while at the same time legitimizing the government's role to compensate the individual for inflicting the wound. One medical provider explained to me the mechanism for getting on SSI in San Francisco. Quote, patients walk into the GA, the General Assistance Office, and on the bottom of that form, there's the box that says, can't do workfare forever. The clinician laughs. Check that off when referred to SSI advocacy. Another physician shared her attempts to avoid hair splitting about the causality of disability and debates about the worthy and unworthy mentally ill. In clinic, she asked herself one question about her patients. Would I hire this person? She says to me, I consider the physical and mental health of the patient in front of me, and I ask myself honestly, can this person currently do a job, any job, for 8 hours a day, 5 days a week? And the answer is often no. The question for me, and it should be for everyone, because it's about work, being able to work. Can this person work? Would I have them work for me? End quote. Lastly, I spoke with a psychiatrist about bipolar disorder and SSI eligibility. She was dismissive. SSI, she sighs. SSI is a bureaucratic exercise. It's over here. She motions away from herself with her hand. It's important. It stabilizes people, might even keep them housed. It doesn't heal anyone. What I'm concerned about is the patient. For women in the daily rent hotels, two specific mental health diagnoses circulated most commonly, bipolar disorder and PTSD. Neurocratic practices that could enable material changes in the lives of pregnant addicts. However, they were also deployed in extraclinical context of what I call street psychiatrics. The story of neurocratic futures in relation to the pregnant addict are bound to street psychiatrics, which are the everyday assessments individual women make about their history, their mental health, the reasons for using or trying to stop using drugs. Mania and trauma are reflected in women's everyday management of addiction and came to form the, quote, new configurations of madness, which characterize their social world and legitimate their biomedicalized governance. Monica and I are walking down Mission Street on a sunny afternoon in June 2008, and we come across a poster in a building for lease. One of the many businesses that is most likely going to transition into a high-end restaurant or bar. The poster catches my attention, so I pause and read it and take a picture. The fine print claims that psychotropic medications actually cause the mental illnesses that are visible in the brain scans shown here, because all these scans are taken of people on medications. The poster reads, quote, look kids, this is your brain on psych meds, playing off of the anti-drug campaigns of the 1980s, which implied the user's brain becomes fried, like an egg in a frying pan as a result of drug use. I ask Monica what she thinks about it. She says, I don't know. I stopped taking mine, or psych meds she's referring to. They were giving me really bad dreams. It didn't feel right. They made me sleep all the time, and then the dreams came. Both Monica's trips to the psychiatric emergency room have been based on 5150 arrests after sexual assaults. 5150 is the police code for a mandatory arrest followed by a 72-hour mandatory lockdown of psychiatric hospitalization for harm to self or others. Remembering these incidents, Monica described herself as, quote, so traumatized, so out of my mind, that being in the psychiatric lockdown on a 72-hour hold felt like a, quote, relief. A psychiatrist I interviewed backed up Monica's experience. For a crack smoker, traumatized and hysterical in a mental health crisis, the focus of the psych ER was temporary stabilization and release. Substance use stands in the way of further mental health care, particularly among stimulant users. This is what she said. The mental health system's excuse is that it's always the substance use. We blame it on the substance use and we don't look further than that. And psych emergency services is designed for that. The most common presentation that we deal with, the most common presentation is intoxication with a stimulant. So all we do is give them a benzodiazepine tranquilizer and let them sit around for 10 hours until they clear the drugs, the stimulants. And then they often look a lot better and they are no longer suicidal, and then we send them out the door. It doesn't mean that they don't have other mental health problems. It means that the acute syndrome has passed. And with crack, it lasts not very long at all. So as soon as the doctor and the patient can develop a coherent plan, we kick them out. And they don't look beyond their crack use. And that's unfortunate because there's a lot underneath. Trauma, PTSD is ubiquitous among crack-smoking women. And part of it is that we don't have a lot to offer them. Unless we have something else, unless they have something else, like an identified mental health problem, they can't come into the psych emergency and say, my primary issue is that I'm a prostitute and a crack addict, and expect me to have any good answers for you, or a place to put you, or treatment. And that's sad, because there's nothing. It's like, okay, here's some condoms. I mean, that's as far as we go in terms of intervention. According to this provider, stimulant use could mask symptoms of a mental illness. Yet with stimulant use presentation alone, very little mental health services might be offered to women. These hospitalizations, like the one I just described, are multi-referential. They offered a respite from Monica from the violence of the drug-sex economy. They became a marker for inadequate mental health care for stimulant-using women, according to the provider. And they also are an essential step in the documentation of mental illness for SSI disability claims. So neurocratic claims require new configurations of madness. While PTSD and bipolar disorder are certainly not new, these diagnoses have emergent and currently shifting social history amongst homeless women. Trauma, sorrow, rage, and mania seem to provide a moral compass for the emotional experience of gendered abuse, institutional interactions, and everyday housing instability among pregnant addicts. They also open the doors to social legibility. PTSD, for example, is one compensatory avenue by which advocates and care providers can create a space of social recognition and gain stabilizing economic and housing benefits for women. The prevalence of PTSD is well evidenced in the epidemiological studies, and the manifestation of symptoms is unequivocal, as the other provider indicated, to most of the providers who interact with women addicts on a regular basis. Another psychiatrist who I interviewed put it bluntly, 90% of my patients in supportive housing have PTSD, and with the women it's 100%. Yet for the purposes of the neurocratic diagnosis of PTSD and bipolar disorder, they both have slippery scientific pathways. They're difficult to diagnose in the presence of active stimulant use. Many physicians I interviewed describe the complex biobehavioral interaction of stimulant use and symptomatic manifestations of bipolar disorder, but Ramona gave me the best description of this neurocratic challenge in a McDonald's on Mission Street. She said, listen, here's me with my bipolar disorder, right? And I'm racing, and I'm paranoid, and I'm uncomfortable, and I'm pissed, and I'm really angry, and I'm depressed. Here's you coming down with crack. We act the same. We look just the same. How are you going to say you know? You can't tell the difference. If PTSD and bipolar disorder are tricky diagnoses to document among active substance users, they can be even trickier experiences in which to live without substances. One provider told me the following: I don't blame women for using stimulants. The mania is functional. It allows you to hustle, to get your work done. Smoke crack and it puts everything on hold, so you can be focused and energized and do what you need to do, whether it's turn tricks or hustle up money in some other way. Another physician told me, oh, I know plenty of women who, quote, self-medicate, who've experienced and do experience terrible trauma and abuse, but I don't like the term self-medication. I'm a physician, and I expect that when we talk about medication, we're speaking about something that will improve health or relieve symptoms, and I've never seen crack do that. I've never seen it work. It always makes everything worse. The answer for many clinicians becomes a multi-pronged approach. First, document the diagnosis for billing and stabilize the patient's housing by providing SSI income. Then treat the diagnosis with atypical antipsychotic medications. Atypical antipsychotics have morphed from treatments for schizophrenia to treatments for most, if not all, mental health symptoms typically occurring in a population of urban poor substance users. One physician told me, the newer antipsychotics are very broad spectrum. They work on just about every serious mental illness. They work for depression, they work for schizophrenia. They're main mood stabilizers for bipolar. Some of them have anti-obsessional components. If the patient has a mental illness and you give them a medication from that class, it's probably going to benefit the mental illness to some degree. That is what we found over time. They were first launched to treat schizophrenia only, and then bipolar, now the augmentation of depression, anxiety, insomnia, PTSD. It's everybody. It's just going to keep going. Several physicians also indicated that the increasing diagnosis of mental health disorders among the urban poor, especially bipolar disorder among women, is a direct result of the perception that effective medications exist to treat them. and a full court press by the pharmaceutical companies to prescribe these drugs. One physician used the old adage with me, if all you have is a hammer, everything looks like a nail. Having experienced what I call a neurocratic pregnancy, Lexi offered a similar nuanced perspective when she initially questioned a PTSD diagnosis encouraged upon her by her neurocratic social worker after the death of her daughter in 2004, the note I read earlier. In 2007, she revisited with me the original resistance of the disabled social label by describing a conversation with her mother in which the ordered etiology of her mental health versus substance use disorders were explored. Lexi told me, but the thing is with SSI, I've put it off. Maybe I can work. I've been putting it off because I really don't want to be disabled. This is where I'm at, and I might be able to get a job. And my mom says that I'm just in denial because she says, this is her mom speaking, you have a medical condition. I'm not saying you're crazy, but you've been through a lot of stuff. Drug use has an effect too. And Lexi says back to her mom, I know that. She also says, and her mom says, you've had issues prior to being a drug addict. You had issues since you were a child. The issues Lexi's mother is referring to include being molested by her mother's second husband and being forced by her mother to assume responsibility for Lexi, the baby of Lexi's 11-year-old sister, who was impregnated by her brother. Lexi was excommunicated from her church as a result of having to claim her sister's child as her own. This is how Lexi puts it to me. I've had a lot of things happen to me in my past. All that kind of stuff that happened in my family and being Jehovah's Witness and losing my baby. I mean, I tried to kill myself 3 times when I was younger. I was 9 years old the first time, second time I was 13, I was 22 the third time. I tried seeing a psychiatrist, but I never followed up. I've been on antidepressants, but I quit because I didn't want to be crazy. I didn't want to be on SSI. It was in 2007. In the fall of 2009, Lexi lost another child to a premature birth. She had received a bipolar diagnosis at this point to add it on to her PTSD. Her main focus was SSI medical documentation. She told me, this is what will get me stable, getting my paperwork. This is what I really need. It's the only thing that will help me at this point. So, I began this talk outlining how historical changes in disability eligibility categorization have contributed to a hybridity in diagnosis and treatment of mental illness among the homeless in general and pregnant addicts specifically. On the one hand, local policies and their bureaucratic actors have maintained mental health care services for a population perceived to have extremely high rates of comorbidity, despite efforts to discourage disability entitlements for substance use disorder. On the other hand, neurocratic practices which serve a social service function have stabilized by stabilizing access to housing and basic needs among the poor, are now largely mental health diagnosis dependent. A pregnant addict must be diagnosed with a mental illness to qualify, even as her own providers, psychiatric and medical, acknowledge that key aspects of her trauma and mania are clearly social and environmental in etiology. Even as neurocratic practices have become a stopgap measure that acknowledges trauma and mania in light of federal policy disavowal, comorbidity is now resurfacing in the context of U.S. healthcare reform debates. We've all been made painfully aware these last few weeks that we find ourselves again on the precipice of national reform. Reforms in the healthcare delivery are reinstigating national political debates about worth, fairness, and bureaucratic accountability. And some of these are occurring in light of benefits eligibility stipulations for mental health and substance abuse treatment. Back in October 2009, I attended a conference on addiction health services at the Sir Francis Drake Hotel in downtown San Francisco. The audience for the conference was clinician epidemiologists. The focus of the conference was to discuss the implementation and ramifications of the Paul Wellstone and Pete DiMedici Mental Health Parity and Addiction Equity Act, piece of legislation that was subtly attached to the $700 million bank bailout legislation, or the TARP. H.R. 1424 was signed into law by then-President George Bush on October 3, 2008. Mental health care parity may have been voted in under the radar of public debate, but its implications for the healthcare treatment of millions of Americans with substance use disorders are potentially profound. The Parity law mandates that insurance companies, both public and private, which provide mental health and substance use services, must compensate treatment plans for mental health and substance use conditions on par with physical health conditions. The Parity Act also provides a platform for coalition building in the name of comorbidity that can speak directly to the historic and publicly mediated debate about the malingering poor and addicted that drove disability criteria and changes in the past. Currently caught in the political maelstrom of the Affordable Care Act, the regulatory practices, including the amount and degree to which chronic mental health conditions will be covered, has yet to be written in federal law. However, the Parity Act is expected to move forward with Obamacare. Local systems of neurocratic practice were put in place to ensure the urban poor persons in San Francisco, including the pregnant addicts in the daily rent hotels, didn't fall out of the healthcare safety net when they were denied SSI eligibility. But it was based on cost, a cost calculation of moving people from the city and state to the federal. With the movement forward of the Parity Act in the Affordable Care Act, it's unclear whether the justification for neurocratic practices will still exist fiscally. Overall, the processes of implementation for the healthcare reform policies and their outcomes are currently unclear. However, as recently reported in the New York Times and shown here on the slide, the specifics of implementation and eligibility resulting from the Parity Act are not yet outlined. While it's clear that parity is moving forward, the ongoing struggle in relationship to coverage and eligibility is expected. An anthropological lens can offer what Laura Nader famously coined as the vertical slice in her analysis of childbearing in modern society, in which the analytic eye is trained on the historical influences contributing to the present-day moment, while also examining expertise from the ground up and back again. Today, I hope I've offered a vertical slice of pregnancy, addiction, and mental health in the U.S. welfare state. The backdrop of U.S. health and welfare reform policies currently underscores the conflicts between opposing discourses of addiction in U.S. society. The social suffering that is embodied in Lexi's tears actively competes with accusations of moral failure and public resource exploitation. Neither of these addiction stories can be easily squared with the insistence that because addiction is a, quote, brain disease, locating and intervening at the neurological level is the key priority. Within this context, addicted pregnancy becomes a collision of scientific reasoning, politics, biomedicalization, and everyday suffering. The tagline for the Mental Health and Addiction Parity Act conference read, quote, "Addiction is a disease, let's treat it that way." This is an easy mantra of humanistic social responsibility that can unfortunately sanitize the complex social reality of the pregnant addict. Her poverty, her sex work, her self-described irrational use of crack when she could, quote, quit anytime she wanted to, her growing fetus, her baby born and lost to the state, and then to foster care. Neurocratic futures in the disability economy have emerged since drug and alcohol dependence were both discontinued as medical conditions, which afforded persons federally funded disability benefits. This change necessitated an increased focus on documentation of mental health disorders among drug users. It changed the practices of evidence production and documentation between patients and providers. Mental health diagnoses institutionalized the desperation of traumatized homeless women, but it also got them inside, off the street, into the daily rent hotels, and in some cases even into supportive housing. So neurocratic practices embody the discontinuity between the governance of addiction and mental illness and its emerging rendering in science and public health as an organically based, co-influencing medical condition. In the world of the neurocrat, because of SSI laws and policies, addiction cannot count as a disease. Addiction cannot be the disease that's making someone crazy, despite the research or policy expertise which underscores the co-constitutive relationship between substance use, abuse, and mental illness. Neurocratic logics create an ongoing separation of clinical and bureaucratic reality, both for patients, the homeless, poor, pregnant addicts seeking disability aid, and their physical and psychiatric caregivers. Because of emergent understandings of the addicted brain, psychopharmacological treatments for a, quote, broad spectrum of mental health diagnoses, and the presentation of symptoms that overlap between mental illness and active substance use, accurate psychiatric diagnoses are extremely difficult to make from a clinical perspective. difficult but absolutely essential to leverage the further social benefits afforded by the access to federal disability entitlements. Thanks.